There are many challenges that men face in fighting prostate cancer, including dealing with the resultant side effects that can be seen with treatment. Erectile dysfunction continues to remain a common problem after a radical prostatectomy. June is Men's Health Month, and today we are very lucky to have on the show men's health expert, Dr. Helen Bernie, to give you a contemporary look at how to go about restoring erectile function after a prostatectomy with penile rehabilitation. So stay tuned. So the big question is this: how can men and those who care for them better educate themselves regarding prostate health, the conditions that affect the prostate, and the latest technology in managing these conditions? That is the question, and this podcast will provide the answers. On the podcast, we'll be chatting with experts, innovators, and leaders in the field of urology, sharing useful information with the general public to improve their lives and increase their overall health. My name is Dr. Garrett Pohlman, and welcome to the Prostate Health Podcast. The Prostate Health Podcast is for informational purposes only. Nothing in this podcast should be construed as medical advice. By listening to the podcast, no physician-patient relationship has been formed. For more information and counseling, you must contact your personal physician or urologist with questions about your unique situation. We're definitely thrilled to have Dr. Helen Bernie on the Prostate Health Podcast today. Dr. Bernie is a board-certified, fellowship-trained urologist and the Director of Sexual and Reproductive Medicine at Indiana University. She is also the Andrology Fellowship Program Director, as well as Assistant Professor of Urology at the IU School of Medicine, where she teaches medical students. Dr. Bernie is passionate about men's health, cancer survivorship, and fertility preservation. She treats all aspects of men's health to include male sexual dysfunctions and infertility. Dr. Bernie completed her residency in urology at the University of Rochester Medical Center and went on to complete a 2-year fellowship in sexual and reproductive medicine at Memorial Sloan Kettering Cancer Center and New York Presbyterian Weill Cornell Medical College. She has presented award-winning research in the field of sexual medicine, testosterone replacement in prostate cancer, as well as male fertility. Dr. Bernie, welcome to the Prostate Health Podcast.
Hi, thanks so much for having me.
So when counseling patients on treatment options for prostate cancer, one of the challenges is considering some of the resultant side effects that we can see with treatment. We often talk about how there is no free lunch when it comes to radical therapy for prostate cancer. Erectile dysfunction remains an ongoing problem for many men after a radical prostatectomy. I thought it would be helpful for our listeners if you could initially explain how prostate removal or prostate cancer can affect a man's sexual function.
No, absolutely. So I kind of tell every patient that I see that comes into my office that everyone's going to take a hit to their erections. And the reason why is that our prostate in men, the nerves that control your erections lie along the side of the prostate. So even in the best nerve-sparing surgery, we're still working to peel those nerves off the prostate and then pull them away so that your surgeon can remove all of your prostate and cure you of cancer, which is our goal anytime we're doing a surgical treatment for prostate cancer. So what happens is even in the best nerve-sparing surgery, when you're pulling on those nerves, they get a traction injury and they can be stunned. And that stunning or that traction injury can sometimes take 12 to 24 months to recover before a man's able to have a good erection again or back to baseline where he used to be. Then, in some cases, just based on the cancer or someone's anatomy, we're not able to preserve the nerves, right? And so sometimes we have to take maybe unilateral nerve, or so one side of the nerve. In worst case scenarios, we take both sides. But again, that's because our goal is to cure you of cancer. And we have plenty of treatments on down the road that can help treat the erectile dysfunction.
Well, thank you for that explanation. And I know a lot of men want to know, okay, what are the odds? If I'm going to do this treatment, what's the likelihood of having difficulty? So how common is erectile dysfunction after a radical prostatectomy?
No, this is probably the number one question that I get asked. So again, I tell every patient, everyone's going to take a hit to their erections. No one is safe proof from that. But our goal is to get you back to baseline or to get you as close back to baseline as we can. Now, if you just look at the literature and what does it say? Ranges anywhere, erectile function recovery after radical prostatectomy is anywhere from 54% to 94%. And that's like a huge range, right? You're telling people that like almost 100% of you versus maybe only 50% of you are going to get your erections back. And that's really because of how it's reported in the literature. all of the publications currently that look at erectile function recovery after radical prostatectomy, there's so much variability in them. And some don't even take preoperative measurements. Some don't use validated instruments, which means surveys that we've looked at specifically to assess someone's erectile function before surgery, follow them, and then assess it afterwards. A lot of them are small sample sizes. And there's so many different ways that we can help put people on programs like Penile Rehab that can actually help for erectile function recovery. So as a result of all of that variability and there being so many different ways that people do things, it's really hard for us to get an accurate reporting. In addition, our own health plays a big role in that, right? So if someone is obese, if someone has poorly controlled diabetes, if someone is a tobacco smoker, their age when they have their radical prostatectomy, as well as most importantly, their nerve-sparing status, meaning when they had their radical prostatectomy, were we able to spare the nerves? And if so, then great, we have a lot of things that we can do. And even if we're not able to, the wonderful truth is that we have a lot of great options for men to help them regain their erections.
Well, you've kind of alluded to it in terms of, you'd mentioned rehabilitation and some of these different options to help men. I think that's a good segue to talk about what are some of the available options for trying to regain erectile function after a prostatectomy.
So the good news, like I mentioned, is we have a lot of different ways. So I tell everyone, you don't ever have to think that just because you had prostate cancer, that part of your life is over, or that you won't be able to have that intimacy and that closeness and really restore that erections back. So typically we start with kind of PDE5 inhibitors or pills like Viagra, Cialis, the little blue pill that we hear about everywhere. PDE5 inhibitors are vasodilators. So they're going to increase blood flow and oxygenation into the penis. And by doing so, they're helping with the erectile tissue health. The analogy I tell guys is prior to pelvic surgery or prior to aging and comorbidities and all the other things that can happen in life, most healthy men get about 3 to 7 nocturnal erections in the middle of the night. And so what a PDE5 inhibitor does is it's basically medically mimicking what happens during those nocturnal erections. So it's increasing blood flow and oxygenation into the penis to give a man a rigid erection. Other options that we have include a vacuum erection device. A vacuum erection device is a hollow tube that you purchase either online or at a store that you place over the penile shaft using either a hand or a battery-operated pump. It creates a suction. What that suction does is it's drawing blood into the penis to maintain or achieve an erection. And then most time you slide down a constriction band that acts kind of like a tight hand grip that's going to prevent blood from leaking out of the penis during that time to maintain your erection. There's several different penile rehabs that involve pills. There's several that involve vacuum erection devices. And then when those don't work, we also have something called intracavernosal injections. That's a penile injection. And I know every time I mention that into the office, patients like, you want me to stick what, where? But the truth is that I have about a third of my practice on injections. What that consists of is prior to sexual activity, a man will take a very small needle. We actually use the diabetic syringes. So it's actually one of the smallest needles we have. And they'll draw up a medication that they inject along the side of their penis, not the glands, but anywhere along the side of the penis, typically at 9 and 3 or 10 and 2 o'clock. And then you're able to get an erection with that medication, usually about 10 to 15 minutes after you inject. And so those are 3 different ways and 3 different options that we have to help men engage in penile rehab after they have a radical prostatectomy or some other pelvic surgery. The one nice thing about pills is that it doesn't involve you obviously having to bring a device with you or a medication and an injection, but they take about 45 minutes or more. After you take a oral pill, it takes about 45 minutes to fully absorb in the system for them to work. And then once they're fully absorbed, you just need sexual stimulation for it to work. Versus if someone's using injections, you actually don't need sexual stimulation and they can work right away, which is also why kind of depending on which one of these to choose may depend a lot on a man's nerve-sparing status after their radical prostatectomy. So if you had a good nerve-sparing status or you have intact nerves, you can take the PDE5 inhibitors or the pills like Viagra, Cialis, because you have an intact nervous system to help stimulate arousal and vasodilation. Now, if someone has had a completely non-nerve-sparing surgery or, even a unilateral nerve-sparing surgery where those nerves that were preserved are pretty stunned or there was a lot of traction injury, then oftentimes we start them with intracavernosal injections because you don't need sexual stimulation for those to work and you don't need to have an intact nervous system in the penis for the intracavernosal or penile injections to work.
Now, what are some of the barriers that you've seen with instituting penile rehabilitation?
This is a great question because there's a lot of barriers. And I think probably the most common one that I see with patients is just education, right? Patients not understanding the why about this, or the why penile rehab is important, or why I'm talking to you about sex before you're having your radical prostatectomy. Because the truth is, when someone gets a diagnosis of cancer or prostate cancer, most of the time the patient and or their partner, if they have a partner, are so worried about just, doc, I want to live. Let's save you. Let's cure you from cancer, that they'll say, sex isn't important to me, doc. I just want to live. Let's just get the cancer out. But the truth is that 95% of the time we can cure you from cancer. And these men are living 20 plus years after their treatment of prostate cancer. And that's where this really comes into play, because after the whole nerve-wracking diagnosis and then follow-up and then treatment of the prostate cancer, and realizing that they are now cured of cancer and their PSA is undetectable, now they're like, wait a minute, we can't have sex ever again, or I'm not getting an erection. And so then it becomes a really big deal. So I really educate patients of, why are you meeting with me? And why are we talking about this before you have your radical prostatectomy? So that you understand that I'm in this for the long run with you. We all are anticipating that you're going to do great and you're going to heal. And now we're looking at your quality of life afterwards. How can we optimize your quality of life so that you're able to have that great intimacy and spend that time with your partner? So I think educating them on why we're doing that is really the number one first thing. And if they're seeing a urologist who says, well, I don't offer penile rehab, or I don't believe in that, then they should go see another urologist who specializes in men's health. The other thing with education is when you're first understanding them about how to do the penile rehab program and why they need to do it. Because if you don't explain to them, how to take medication correctly, so they take a Viagra and all of a sudden they see the next day, like, oh, it didn't work, so I stopped taking it. Well, maybe they didn't know that it needs to be taken on an empty stomach or waiting 45 minutes. And just in general, if the pills don't work right away, some men think, well, oh, there's nothing for me, or I just have to wait it out. And that's the last thing we want patients to do. I don't want them to wait 6-12 months after their radical prostatectomy before they come see me, because I want to try to help them right away so we can recover that erectile tissue and keep the penis healthy. So again, educating them why, our long-term goals about all of this, and the importance of taking the medication or whatever penile rehab you're doing it regularly and following it through. I think the next one is compliance, and that kind of goes back to the education part. But a lot of times patients, if they don't understand why they're taking this or it doesn't work right away, they stop taking it and they wait, like I mentioned. And so the best way to get people to take stuff and to stay compliant is to explain it to them so that they know exactly why they're doing it. And then also cost impacts compliance. When Viagra first came out in 1998, it was like, I don't know, $25, $40 a pill. It was ridiculous. And some people's insurance, it's still that much because they're not covered by insurance. But the good news now is that we have all of these other drug assistance programs like Good RX or Mark Cuban's Cost Plus Drugs, where you can really get these medications now for pennies, cents on the dollar. So thankfully, cost hasn't been a really big issue, but let's say pills don't work. Now you're looking at costs for intracavernosal or penile injections. And most of the time, those aren't covered by insurance. And so how we kind of go about that is we'll use compounding pharmacies or places where you can get it a little cheaper, where you can buy larger vials of the medication. But cost still can be a barrier for many patients, especially patients that are really just month to month trying to pay their bills. So that's kind of one of the other issues. I think the last issue that I find with a lot of our patients as being one of the barriers too, is that what if you don't have a partner, right? Or if you don't have a partner, then guys will be like, well, I'm not having sex because I don't have a partner. And that's really where, again, going back to number one, that education is you kind of teach them that when someone has a knee replacement or someone's having a rotator cuff surgery, you go to physical therapy to rehab yourself. This is your penile rehab. This is your sexual health, which is just as important as your physical health. And it's a marker of your overall health. And so I tell guys that, look, this is your physical therapy to regain your erections back to baseline and to get you where you can have that intimacy and that confidence when you're with your partner. So again, I just kind of talk to them about making sure that they're consistent, that they're diligent, and that if anything changes or they're not noticing, maybe initially they were getting good erections and now all of a sudden it's dropping off, give me a call. If they're having side effects on their medication, give me a call. There's a lot of things we can do to switch things up or change it as long as there's good communication. So for that reason, I tend to follow these patients every 3 months. So I see my patients before surgery, then shortly after surgery, and then every 3 months for a time period. And that's really just so that we can touch base, right? I can hear, how's everything going? Are you having any challenges with anything? Are the pills still working? Or if you're using injections, is it painful? Have you had any problems injecting? And you can really get that back and forth with your patients. That really helps you be able to empower them so that they can stay on the plan, so that the end goal is we're restoring their quality of life so that once that prostate cancer is cured, they can go back to where they were before surgery.
I think one of the challenges for urologists with penile rehabilitation has been the lack of a standardized approach. And as a result, we have seen significant variability worldwide in how this is done. When considering your review of the current literature, I know our listeners would love to hear your current penile rehab protocol at Indiana University. Could you walk us through your current approach?
Yes, I'd be happy to. So most of the time, and my preferred way is that I see patients before their surgery. And that can be a month before surgery, a week before surgery, a few days before surgery. But the ideal time would be to see them before surgery. So I try to see patients before surgery. Where I can't see them before surgery, I see them 6 to 8 weeks after their surgery. And I think that that's important because typically I have patients start penile rehab about 3 weeks after surgery. So their Foley catheter is taken out and I want them to start getting erections. Let's see how everything's going. So we see them before when we can. When we can't, I see them about 6 to 8 weeks later. My penile rehab plan, if it's been a unilateral nerve sparing or a nerve sparing surgery in general for both sides, bilateral, I start them on a daily PDE5 inhibitor. So that's Viagra or Cialis. And either one is fine. You know, they're very similar medications. Some have a little different side effects, but some people have preference, some don't. And so I start them on a daily pill that they're going to take every day. And again, I tell them this is basically medically mimicking their nocturnal erections. And they're not going to take it every day and walk around with an erection, which is what people worry about. Because again, this medication works with sexual stimulation. So they're going to take it every day like a multivitamin for 1 year out from their surgery. And then starting at that 3-week mark, they're going to start doing what's called a challenge dose. That challenge dose is either the maximum dose, so 100 milligrams of sildenafil or Viagra, or 20 milligrams of Cialis or tadalafil, at least once weekly with sexual stimulation. And that sexual stimulation can be with a partner or it can be by themselves, but they're going to do that at least once a week. It's totally fine if they want to do it more than once a week. But the goal is that at least they're doing it once a week. And most of our current data would show that that's sufficient for erectile tissue health. And then I see them again every 3 months until they're at the 1 year mark after a radical prostatectomy. Now, in patients that have had radiation therapy, I see them every 3 months till it's been 2 years out, just because the penetration and penetrance of the radiation can impact the tissues a little bit longer. So I'll recap it real quickly. So I see them either before surgery and I start them on the PD5 inhibitors then if I see them before, at least that low dose daily. Then 6 to 8 weeks out from surgery, I see them. They start trying their challenge dose at 3 weeks out when their Foley catheter's already been removed. And at that 6 to 8 week, I'm asking them a lot of questions. Hey, are you getting any erections? Are you taking the daily meds? Are you taking your challenge dose? And where were your erections on that scale of 1 to 10? If they are not getting a penetration hardness erection at that visit, or at any of the 3-month visits following, maybe it was okay at first and now it's declining. It's usually the other way around. But if that's the case at any point in time, then we say, hey, now I'm going to switch you to injections. So if they're not getting a good erection with the maximum dose of a pill, like a PDE5 inhibitor, then I start them on penile injections. And so now that takes the place of that weekly challenge dose. So they'll take daily PDE5 inhibitor and once a week challenge dose with either maximum pills or the penile injections. And they're going to continue doing that for an entire year out from their radical prostatectomy. And I can't tell you how many patients we have, even ones that have had unilateral nerve sparing, that when they first started, they weren't able to get a good erection with pills. We had to transition them to injections. And then around that 10 to 11 month mark after surgery and those nerves are waking up, now they're able to get a good erection back on medications like Viagra or Cialis, and they no longer need the penile injections. So I just think that that's kind of the importance, again, of reminding them this is a marathon. This is an end goal. And if you had healthy erectile tissue before surgery, we're going to help you get back there as close as you can back to baseline with getting you a good erection, whether that's with or without the aid of a medication. Radiation is the same. Like I mentioned, I do that to about 2 years. And every now and then I have a patient that absolutely needle phobic, right? I absolutely hate needles, doc. I am never, no matter what, I don't care. You can't get me close to injecting myself down there with a needle. And they're not responding to the maximum dose of pills. It's those patients that I would then recommend either a vacuum erection device, or if, depending on the patient's circumstance, you can also talk about a penile implant in those patients. But usually that's rare, but I do have some patients that, don't want to go through all of that. And that's where a vacuum erection device will work.
Well, certainly an excellent review of your protocol. And I think it's very helpful for our listeners, men and their loved ones, to hear that, just kind of more somewhat reassurance that even though that things aren't really happening just yet, that, like you said, down the road, you can even potentially come off injections if you're needing injections and just go back to the oral therapy with the pills. And so I think that's good just for them to hear that, but also I know we have a lot of our colleagues, urologists, listening in just to see how Dr. Bernie does it and just to kind of hear your protocol and just to kind of hear how you're doing it and the success you're having in your program. So thank you so much for going through that.
For other urologists, I can hear them saying, well, how do you have time to see every patient back? This huge amount of radical prostatectomy patients every 3 months that are on your penile rehab. But that's really where I use virtual visits all the time, because I don't need to see them in person to ask them the quick few questions about, are they still having climacturia or leakage of urine, or how are their erections? Are they taking their medications? I can pick up the telephone and do a virtual visit, or I can do an audio visual visit. And it takes 5 to 7 minutes out of my day most of the time. And then you just kind of do a quick visit. So I think there's another plug and really big role for telehealth here, because it allows me to see these patients that I don't need to see in person, that they don't need to take up an office-based visit, that are really quick patients that you're just following up, every 3 months to make sure that, hey, is everything going well? And to maybe even give encouragement to some of those that are really struggling, right? One of the barriers I did not talk about, just now thinking about it, was there's some patients that have like incontinence, right? Urinary incontinence, or they're really struggling after their radical prostatectomy. And in those patients that have urinary incontinence, of course, they're not thinking about getting an erection. They're not wanting to leak or get their partner wet. And we have treatment options for those things too. And so again, I think having that regular follow-up and touching base with patients to know how's everything going, we can help kind of troubleshoot those things too. We can troubleshoot any urinary leakage that may be a barrier for why they're not using their penile rehab program appropriately, or, if they're just kind of being discouraged, reminding them that, like, hey, you're going to get there, keep doing what you're doing, stick with the program, and we're going to see the final end result.
So Dr. Bernie, any final thoughts today for our listeners?
I think the most important thing is anyone that's maybe just been told that they have prostate cancer diagnosis, or that's suffering with erectile dysfunction in general, go see someone and ask them about a penile rehab program. Ask them what it entails. If they're a provider, if your surgeon doesn't do that or he's not familiar with that, there's many of us who do, many of us who offer virtual visits if you're not in a location that's nearby. But to really educate yourself, talk to your family, talk to your friends, because most of the time we can cure you of cancer and we can regain that quality of life back too. This is not something that you have to go without. We can regain those erections, we can help with continence, and we can really optimize you.
Well, thank you so much for taking time out of your busy schedule to help educate our listeners. Just solid gold. I know I can speak on behalf of all of our followers here on the podcast that we greatly appreciate you delivering your wisdom, and that we're all going to benefit. So thank you again.
Thank you so much.
Thank you again for listening to the Prostate Health Podcast. For those of you wanting to dive in even deeper, make sure to check out the Prostate Health Academy, which offers comprehensive and easy to navigate lessons that I have prepared for you. There's also an active private community forum, and I am there every day providing support, insight, and answering questions. To learn more, just go to www.prostatehealthacademy.com and click on Join Now. Well, that's it for today. We will see you at the next episode.